biotransformation of drugs. Biotransformation of drugs are also denoted by metabolism, but the better term is biotransformation. So what is biotransformation? Basically a drug undergoing metabolic transformation in the body, enzyme mediated, so that the drugs can be easily excreted from the body. So why it is needed? So that the most of the drugs what we consume, they are non-polar or lipophilic, and what happens when they reach the renal tubules, they are reabsorbed. So to convert non-polar or lipid soluble compound to the polar lipid insoluble, biotransformation is needed. In the absence of biotransformation, most of the drugs will be retained in the body, and that will cause the therapeutic effect of the drug for a very long time. Most hydrophilic drugs like streptomycin, like neostigmine and pancuronium, they have got quaternary ammonium ion, so they are polar, are little biotransformed and largely excreted unchanged. Now, detoxification and drug metabolism are interchangeably used in place of biotransformation, although not correct. Biotransformation means enzyme catalyzed biochemical transformation of drugs within the living organism. Now, the primary site of drug metabolism is liver, but drug metabolism does not only take place in liver, it can take place in the intestinal wall, it can take place in the lung, in the skin, in placenta, plasma. Now, what are the consequences of biotransformation? Either the drug which was active in the body is inactivated by biotransformation. This is a number one consequence. Next, the drug was prior active. After metabolism or biotransformation, some other form of active drug is produced. So active drug is converted to the active metabolite. Number three, the drug was inactive when taken, and after biotransformation, the drug became active. These type of drugs are called prodrugs. Prodrugs generally refers to the drug which are inactive as such, but when taken, when consumed, due to metabolism, the active metabolite is formed. So, consequence of biotransformation, number one, inactivation. Most drugs and their active metabolites are rendered inactive or less active. Examples are ibuprofen, paracetamol, lidocaine, chlorpheniramine and others. Thus, biotransformation provides an alternative method of elimination of drugs. Active metabolite from an active drug. The drug is active and then active metabolite is produced. Many drugs have been found to be partially converted to one or more active metabolite, and the effects are sum total of the active drug and the active metabolites that are produced. These are the examples of the active drug converted to active metabolite. Like morphine. Morphine is an active drug. It is converted to morphine 6-glucuronide. It's again an active metabolite. Cefotaxime, acetyl cefotaxime, allopurinol, alloxanthine, prokenamide in acetyl prokenamide, primidone, phenobarbital, phenyl ethyl malonamide. Now coming to the third point, third consequence, activation of inactive drugs. Few drugs are inactive as such and need conversion to one or more active metabolites, and such drugs are called prodrugs. The prodrug may offer certain advantages over the actual drug. Why not the active drug is directly consumed? In those cases, why the prodrug is consumed? Because number one, the prodrug may be more stable. That is why it is taken in the form of prodrug. It can have better bioavailability. Bioavailability, माने जानो? What is meant by bioavailability? Anyone? Tell? Yes? Actually, it's the percentage of the drug available from it's the percentage of drug available for action after the drug is consumed. So it may have better bioavailability, certain better pharmacokinetic properties. It can have lesser side effects and toxicity. These are the advantages. Why we are taking prodrugs in those cases. Some prodrugs are activated selectively at the site of action. Now, these are examples of the prodrugs like levodopa. Levodopa is an anti-Parkinsonian drug. Now, it's a prodrug. In the body, it is converted to dopamine. It's the active metabolite. Enalapril is an antihypertensive drug. It is the active form is the enalaprilat. Alpha methyl dopa, alpha methyl norepinephrine, dipivefrin, epinephrine, proguanil, cycloguanil. So these are some of the examples of prodrugs. This can be asked in the exams and even in the viva. Examples. Now come to the classification of biotransformation. We can divide the biotransformation of drug in two phases. One is phase 1, also called as non-synthetic functionalization reactions, and phase 2 also called synthetic and conjugation reactions. Now, what happens in phase 1 biotransformation? Here of functional, the drug was initially lipophilic. A functional group is added like hydroxyl group, like carboxylic acid group, like sulfhydryl group, so that the drug can become polar. Either it is added or it was within the drug, it is exposed, so that the drug becomes polar, leading to active or inactive metabolite. These reactions are mainly microsomal, we will come to it later on, and include oxidation, reduction or hydrolysis reactions. Now coming to the phase 2 reaction, what happens here? Here an endogenous radical is conjugated to the primary drug or the metabolite. An endogenous radical is conjugated to the drug metabolite, rendering it mostly inactive. Certain drugs already have a functional group and can directly undergo phase 2 metabolism. Some drugs, they already have the functional group in them and they do not undergo phase 1 metabolism, they can undergo phase 2 metabolism directly, while others undergo a phase 1 reaction followed by phase 2 reaction. Now, these reactions may be catalyzed by microsomal, mitochondrial and cytoplasmic enzymes. The metabolite formed is polar, hydrophilic and can be easily excreted by urine. Now, the drug metabolizing enzymes can be divided into two groups. One are microsomal enzymes, those are located in the smooth endoplasmic reticulum, and the others are non-microsomal enzymes located in the cytoplasm and other places. So, microsomal enzymes, these are located primarily on the smooth surface endoplasmic reticulum of the liver. However, they can be also present in the intestinal wall, in the lungs, in the kidney even. The primary enzymes included in the microsomal group are mixed function oxidases or the cytochrome P450 and also the glucuronil transferase. Now, this glucuronil transferase, they come under phase 2 reaction, and these cytochrome P450 system, they come under the phase 1 reactions. So, microsomal enzymes can basically can be responsible for phase 1 and in some cases phase 2 even. They are non-specific in action, these enzymes does not cause the metabolism of a single drug or a specific drug. They cause the metabolism of multitude of drugs. These are non-specific, can be induced or activated. Certain activating factors can induce these enzymes and can metabolize only lipid soluble drugs. They are concerned primarily with phase 1 reaction, but phase 2 glucuronil conjugation also occurs by microsomal enzymes. Now, coming to the cytochrome P450, these are hemoproteins. Why they are called cytochrome P450? because in the reduced form they can combine with carbon monoxide and the product that is formed that has got absorption peak at 450 centimeter. So they are called cytochrome P450. Now it's not a single enzyme. They have got basically a group of enzymes, and each of the enzyme is numbered. These enzymes basically they are classified into families by giving a number 1, 2, 3, 4 and others, and again they are given subfamilies by the alphabets A, B, C, D and others, and individual enzymes and again numbered 1, 2, 3, 4. For example, you consider CYP2D6. It's an enzyme, it's an individual enzyme belonging to cytochrome P450 system, having family 2, subfamily D and 6 is a gene number. In humans, though there are many enzymes, in human only 12 cytochrome P450 enzymes are responsible for the drug metabolism. These include CYP1A1, 1A2, 1B1, 2B1, 2A6, 2B6, 2C8, 2C9, 2C19, 2D6, 2E1, 3A4 and 3A5. Of them, 50% of the drug is metabolized by CYP3A family, rest 25% by CYP2D. Now, these enzymes exhibit genetic polymorphism, means they show genetic variation, some of them. The relative amount of different CYP450 differs among species and among individual. So, the rate of drug metabolism shows inter-individual and inter-species variation. Now, coming to the CYP3A4 and CYP3A5 is the most important cytochrome P450 enzyme. Nearly 50% of the xenobiotics including drugs are metabolized by this cytochrome P enzyme, because these are present not only in liver but also in intestine and kidney. CYP3A5 is usually less active. Inducers, the factors that induce or activate these enzymes are barbiturates, carbamazepine, phenytoin, rifampin, and the inhibitors are erythromycin, clarithromycin, ketoconazole, fluconazole, verapamil, diltiazem, ritonavir and grapefruit juice. CYP2D6, these are responsible for metabolism of the 25%, around 25 to 30% of the clinically used drugs. Its important inhibitors are quinidine, fluoxetine. Inducers are less known. They show greater incidences of genetic polymorphism. Certain individuals, they are deficient in CYP2D6 or enzymes in them may be less active, like codeine. Codeine is used as an analgesic drug. Now, this is metabolized by CYP2D6 enzyme. What happens? The person having deficient or inactive CYP2D6, they lack the analgesic action of the codeine. CYP2C8 and CYP2C9, these are responsible for around 10% of the commonly used drug metabolism. Barbiturates and rifampin are its inducers. Inhibitors are less known. CYP2C19 around 12 to 15 in numbers, just induced by barbiturates and rifampin. Inhibitors are less known. The drugs that are metabolized include diazepam and omeprazole. CYP1A1 and CYP1A2. Now, only a few drugs are metabolized. These include theophylline, warfarin, clomipramine and paracetamol. These are induced by several drugs and other pollutants that include barbiturates, rifampin, carbamazepine, smoking and charcoal, broiled meat. CYP2E1, very few drugs are metabolized, including general anesthetics drugs like halothane, influrin, alcohol, paracetamol. Now, paracetamol is also metabolized by CYP2E1, and by this is a minor pathway, and by this metabolism, a metabolite is formed that is toxic to the liver. Hepatotoxic metabolite is formed. Okay, that is NAPBQI, N-acetyl benzoquinoneimine. That is the metabolite that is hepatotoxic. What happens? Chronic alcoholism, it induces the enzyme CYP2E1. So enzyme becomes more active. So what happens? More paracetamol is metabolized, more hepatotoxic metabolite is formed. So paracetamol in chronic alcoholic patient can show hepatotoxicity. Non-microsomal enzymes. These enzymes are present in the cytoplasm, mitochondria of the hepatic cells and other tissues and in plasma. Now examples are monoamine oxidases, esterase, amidase, transferase, conjugase. Reactions catalyzed by them are all phase 1 reactions except glucuronide, which are phase 2 reaction, certain oxidation, reduction and hydrolytic reactions. These are non-inducible, they are not activated, but can be inhibited and usually show genetic variation, like pseudocholine esterase, we will discuss it later, acetyl transferase and others. Now coming to the phase 1 reactions one by one. These include oxidation is the most common reaction, reduction, hydrolysis, cyclization and decyclization. Oxidation. What happens in oxidation? Either addition of oxygen or negatively charged atom or removal of hydrogen or positively charged atom can lead to oxidation reaction. It is the most important drug metabolizing reaction. These are carried out by a group of monooxygenase in liver, which is the final step that involves cytochrome P450, NADPH, CYP450 reductase and molecular oxygen. They include hydroxylation, oxygenation at C, N or S atom, N or O dealkylation, oxidative deamination. Now, barbiturates, phenothiazines, imipramine, propranolol, ibuprofen, paracetamol and others are oxidized in this way by cytochrome P450. In addition, few drugs like cimetidine, ranitidine, clozapine, they are oxidized at N, P or S atom by a group of enzymes called flavin monooxygenase. It is a non-microsomal enzyme that are located on, others were microsomal, that are located on the hepatic endoplasmic reticulum but distinct from the CYP enzymes. Flavin monooxygenase, they are not inducible. So, the two drugs having the same function, cisapride and etopride, they were used for the treatment of gastrointestinal disease, particularly GERD. Cisapride is metabolized by cytochrome P, while etopride, this is metabolized by flavin monooxygenase. Now what happens when cisapride was used with other drugs that were inducing cytochrome P, like inhibiting, like ketoconazole, what happens? The cisapride concentration increases and that can lead to fatal arrhythmia. So the cisapride was withdrawn from the market. But etopride, as it is metabolized by flavin monooxygenase, it is not inducible. So if it co-administered with other drugs also, cardiac arrhythmia does not ensue. Reduction, this reaction is the converse of oxidation. Here either oxygen or negatively charged particle is removed or hydrogen or positively charged particle is added. Alcohols, aldehydes, phenols are reduced. Drugs primarily reduced are chloral hydrate, it is a non-microsomal, chloramphenicol, halothane and warfarin. Hydrolysis, here water is added to the drug and then it is broken down. It is a cleavage of drug molecule by taking up a molecule of water, ester plus H2O leading to acid and alcohol by enzyme esterases. Similarly, amides, polypeptides, they are hydrolyzed by amidase and peptidase. Epoxide hydrolase, they detoxify epoxide metabolite of some drugs. Example of drugs metabolized by hydrolysis are microsomal pethidine lidocaine, non-microsomal procaine, atropine, procainamide, beta-lactam ring of penicillin G. Cyclization, as the name suggests, is basically forming of a ring structure from a straight chain compound. Example, cycloguanyl is formed from the proguanyl. Dicyclization, this implies opening of the ring structure. Examples, barbiturate and phenytoin is a minor pathway. Coming to the phase 2 metabolism or biotransformation. Here endogenous radical is added to the phase 1 metabolite or the drug. Now usually derived from the carbohydrate or amino acid. As a result, more hydrophilic metabolites are formed. It's a high energy requirement reaction, and phase 2 reactions are generally faster than phase 1 reaction. Now, number 1, glucuronide conjugation is a microsomal reaction. This is the most important synthetic reaction carried out by a group of uridine diphosphate glucuronosyl transferase UGTs in the presence of a cofactor UDPGA, uridine diphosphate glucuronic acid. Now, compounds with a hydroxyl or carboxylic acid group are easily conjugated with glucuronic acid, which is derived from glucose. Examples are chloramphenicol, aspirin, paracetamol, diazepam, lorazepam, morphine, metronidazole. Not only the drugs, certain endogenous hormones like bilirubin, steroidal hormones and thyroxine are metabolized by this pathway. Glucuronide increases the molecular weight of the drug so that it favors excretion in bile. What happens in the when it is excreted in the bile in the intestine, they are metabolized. Drug glucuronide excreted in bile can be hydrolyzed by the bacteria in the gut, and what happens? The drug is liberated. It is again reabsorbed. And again it is glucuronidated. So enterohepatic cycling occurs with this sort of metabolites, and that prolong the action of the drug. Example, phenolphthalein, oral contraceptives. Acetylation, as the name suggests, an acetyl radical is added to it. This drug RNH2 acetyl-CoA is the cofactor, and it is catalyzed by the enzyme in acetyl transferase. Phase 2 reactions, they require one cofactor and the enzyme. The cofactor here is acetyl-CoA, which is the acetyl donor, and the reaction is catalyzed by N-acetyl transferase. It takes place in the cytoplasm of various organs, and the drugs that are metabolized by this pathway are sulfonamides, hydralazine, isoniazid, very important, procainamide, PAS, dapsone, clonazepam. Now, multiple genes control the NATs, and rate of acetylation show genetic polymorphism. As already discussed in the previous class, the person shows genetic polymorphism with respect to acetyl transferase. They are two sort of individuals. One is slow acetylators and one are fast acetylators. Methylation, here methyl radical is added. The cofactors are methionine and cysteine, and the enzyme is methyl transferase. Examples: adrenaline, histamine, nicotinic acid, methyl dopa, captopril and mercaptopurine. Sulfate conjugation, sulfate radical is added by the enzyme sulfotransferase. Examples: chloramphenicol, methyl dopa, adrenal and 6 steroids. Glycine conjugation, glycine is added. Salicylate, nicotinic acid and other drugs are metabolized by this pathway. It is a minor pathway of metabolism. Glutathione conjugation. The enzyme is glutathione S transferase, forming a mercaptopurate. It is normally a minor pathway. However, it serves to inactivate highly reactive quinine or epoxide intermediate. When large amount of drugs of such intermediates are formed, like in case of poisoning, paracetamol poisoning, when large amount of such intermediates are formed, glutathione supply falls short and toxic intermediates are formed, resulting in hepatic, renal or other tissue damage. Ribonucleoside nucleotide synthesis is important for the activation of many purine and pyrimidine antimetabolites, that are anti-cancer drugs, again a minor metabolic pathway. Now, these are the sequences of the drugs undergoing biotransformation. Drug may not undergo any sort of metabolism, can be directly excreted, is the one way. Drug may undergo phase 1 metabolism followed by phase 2 is the second way. Drug can undergo phase 1 metabolism followed by excretion, did not undergo phase 2 metabolism. It may occur even drug may undergo only phase 2 metabolism and then excretion. It may also occur. Now, stereoisomers, various chemical compounds, they have got stereoisomers, R enantiomer, S enantiomer. Stereoisomers of a drug may be metabolized differently with different rate. Example is enantiomer of warfarin, H warfarin. They rapidly undergo ring oxidation while R warfarin is slowly degraded by side chain reduction. Only a few drugs are metabolized by enzymes of intermediary metabolism. They do not undergo phase 1 or phase 2 metabolism. Like alcohol. Alcohol is metabolized by alcohol dehydrogenase enzyme. Like allopurinol. Allopurinol basically is metabolized by xanthine oxidase. Succinylcholine metabolized by pseudocholinesterase and others. Now, non-enzymatic biotransformation. This is about the enzymatic biotransformation. A handful of drugs, only few drugs, particularly C. atracurium, they basically get inactivated in the body by themselves by molecular rearrangement. Okay, they do not require any sort of enzyme for metabolism. So, this refers to inactivation of the drug in the body fluid by spontaneous molecular rearrangement without the agency of any enzyme. Particularly, C. atracurium and atracurium. These are the skeletal muscle relaxant, and as they are undergoing by undergoing excretion from the body by non-enzymatic method, by non-enzymatic elimination, they do not require the presence of liver or kidney for their elimination, and hence these drugs can be used in patients of hepatic and renal failure without any dose adjustment. Microsomal enzyme induction. Now, many drugs, insecticides, carcinogens, they interact with DNA, increase the synthesis of protein, microsomal enzyme proteins, especially cytochrome P450 and UGTs. As a result, the rate of metabolism of the inducing drug itself, that is called autoinduction, or some other co-administered drug is accelerated. What do we mean by autoinduction? Basically, when a drug is given in the body, when a drug is administered, it increases the rate of metabolism of itself. That is called autoinduction. Examples like carbamazepine. Carbamazepine is an anticonvulsant drug that shows the feature of autoinduction, like barbiturates. So, as a result, the rate of metabolism of inducing drug itself and or some other co-administered drug is accelerated. Okay. Enzyme induction, although most prominent in liver, can occur to some extent in intestine, lung, placenta and kidney. So, how the induction is occurring? Induction is occurring because of the increase in synthesis of protein, enzyme proteins. That requires some time because the DNA has to be influenced, the protein synthesis has to be increased. So, it takes around 1 to 2 weeks time for full effect. And again, when the drug is withdrawn, the effect does not go instantaneously. It takes again 1 to 2 weeks time. Now, different inducers are relatively selective for CYP450 isoenzyme families. Example, anticonvulsants, phenobarbital, phenytoin, carbamazepine, rifampin, glucocorticoids, they induce CYP3A isoenzymes. Phenobarbital and rifampin, they induce CYP2D6 and CYP2C8, 2C9. Carbamazepine and rifampin, CYP2C19, CYP1A1, 1A2. Isoniazid and chronic alcohol intake induce CYP2E1. Polycyclic hydrocarbons, cigarette smoking, charcoal boiled meat, omeprazole, industrial pollutants, CYP1A. Other inducers are nevirapine, glycofulvin, DDT. CYP3A is very important. You should know its inducers, know its inhibitors. That is asked in exam, in viva, even in MCQs. Right? 2E1, chronic alcoholism, very important. Now, clinical relevance of enzyme induction. So, what the clinical relevance for enzyme induction? Number one thing, because of enzyme induction, there may be increase in drug metabolism. So, what will happen? Number one, because of increase in drug metabolism, the administered drug may show less effect. The co-administered drugs, their effect may decrease, and the co-administered drugs, their effect may increase again if the metabolite is active. Enzyme induction can lead to drug toxicity, and enzyme induction is also used for certain therapeutic benefit for the treatment of disease. We will be coming one by one. Now, examples of consequences of increased drug metabolism by enzyme induction. OCP, oral contraceptive pills, they are used to prevent unwanted pregnancies. What happens when OCP is co-administered with enzyme inducers like phenytoin and rifampicin? What will happen? The metabolism of OCP will increase, the contraceptive efficacy will decrease. That will lead to contraceptive failure. Number two, patients on enzyme inducing drug like barbiturates, if oral anticoagulant like warfarin is administered, what will happen? If barbiturates are enzyme inducers, they will increase the metabolism of warfarin. Warfarin effect will decrease. The dose of the drug has to be increased. If in these patients the barbiturate is withdrawn, the toxicity of warfarin will increase. As a result, bleeding tendency will occur. Bleeding will occur. Now, barbiturate, if barbiturate basically, they enhance their own metabolism also, called autoinduction. Enzyme inducers like phenytoin, they accelerate the metabolism of vitamin D3, leading to osteomalacia. Now, enzyme induction leading to drug toxicity. As said earlier, chronic alcoholic patient taking paracetamol. Chronic alcoholism basically induce CYP2E1 enzyme, and this enzyme is responsible for the production of hepatotoxic metabolite from paracetamol. So, when chronic alcoholic patient is taking paracetamol, the enzyme is already induced. So, more and more hepatotoxic metabolite is produced. Possible uses of enzyme induction. Number one, in congenital hemolytic anemia. In newborn baby or in premature baby, basically they deficiency of glucuronide enzyme. So what happens? Basically they show congenital hemolytic jaundice occurs due to deficient glucuronidation of bilirubin. Now, when phenobarbital is used in these patients, it hastens the clearance of jaundice. Why? Phenobarbital basically is a barbiturate, it's an enzyme inducer. So, it will increase the clearance of jaundice. Cushing syndrome, phenytoin is used to reduce the manifestation of enzyme degradation of adrenal steroids, which are produced in excess. In Cushing syndrome, adrenal steroids are produced in excess. Now, what happens? Phenytoin, being an enzyme inducer, it increases the metabolism of these steroids. Chronic poisonings by faster metabolism of the accumulated poisoning substance and liver disease. Coming to the next point, enzyme inhibition. Now, one drug may inhibit the metabolism of other drug with resultant increase in the circulating level of slowly metabolized drug. যদি একটা drug এর metabolism inhibit করা হয় তার লেভেলটা বেড়ে যাবে, and that cause prolongation or potentiation of the pharmacological effect. Enzyme inhibition can either be of hepatic microsomal enzyme or of enzymes having specific function, like xanthine oxidase is inhibited by allopurinol. Allopurinol is basically hypouricemic drug. Monoamine oxidase, aldehyde dehydrogenase and others. It's a rapid process unlike induction and is usually reversible. Now, it's not very clear. Some important enzyme inhibitors are cimetidine for cytochrome P450, sodium valproate, erythromycin and ciprofloxacin. Chloramphenicol, allopurinol inhibit xanthine oxidase, MAO inhibitors inhibit monoamine oxidase, Disulfiram, metronidazole, they inhibit aldehyde dehydrogenase, ecothiophate, acetylcholine esterase and others. Now potentially adverse consequence of enzyme inhibition. Basically a patient taking on theophylline, if chloramphenicol or erythromycin are co-administered, what happens? The theophylline metabolism will be decreased. There will be more theophylline level in the blood and leading to unexplained nausea, vomiting and tremor. These are the side effects. When dicumarol is an oral anticoagulant drug. Now, when it is co-administered with cimetidine, which is enzyme inhibitor, there will be enhanced bleeding tendencies. Morphine, when co-administered with monoamine oxidase inhibitors. Now, these are metabolized by these enzymes, so morphine level will increase. There will be severe respiratory depression. Now, a patient on phenytoin with dicumarol or chloramphenicol, phenytoin toxicity can occur leading to severe ataxia and drowsiness. Terfenadine is banned in India nowadays. When taken in combination with chloramphenicol or ketoconazole, severe precipitation of cardiac arrhythmia may occur, and that is the reason the drug has been withdrawn. Now, what are the beneficial effect of enzyme inhibition? Number one, levodopa co-administered with carbidopa. Levodopa is an anti-Parkinsonian drug, but it's a prodrug. It is converted in the body to dopamine, and this dopamine acts on the brain. So why dopamine is not consumed directly? Because the problem with dopamine is that it does not cross the blood-brain barrier. As a result, it cannot reach the brain and cannot show its therapeutic efficacy. Now, when taken as levodopa can cross the blood-brain barrier and can reach the brain and can show the effect. It is converted to dopamine in the brain because of the presence of decarboxylase enzyme and show its effect. Now, this levodopa is metabolized peripherally also by decarboxylase enzyme to dopamine. So, some of the levodopa can't work, some reach in the brain in a small quantity. Now, this carbidopa is a peripheral decarboxylase enzyme inhibitor. So, more and more levodopa will reach the brain and hence there is synergistic effect. So, increased availability of levodopa in brain when given along with carbidopa. Number 2, aversion to alcohol after prior administration of disulfiram. Disulfiram is an acetaldehyde dehydrogenase enzyme inhibitor. Now, how is the alcohol metabolized in the body? Alcohol is metabolized by alcohol dehydrogenase to acetaldehyde, and acetaldehyde is again converted to acetic acid by acetaldehyde dehydrogenase. Now, this acetaldehyde dehydrogenase enzyme is inhibited by disulfiram. So, what happens when a patient on chronic alcohol they take disulfiram? So, what will happen? More and more acetaldehyde will accumulate in the body and that lead to nausea, vomiting and headaches, flushing. Okay. So, if a patient is already quitted alcohol, if we put him in disulfiram, the patient if accidentally consume alcohol, he will not feel good. He will be having problems like nausea, vomiting, headache, and so he will not further try to take alcohol. So, aversion to alcohol after prior administration of disulfiram. Again, D-tibocurarine is a skeletal muscle relaxant. Now, its effect can be counteracted by neostigmine, which is acetylcholinesterase reversible inhibitor. Now, coming to first pass metabolism. First pass metabolism টা কি হয়েছে? একটা ড্রাগ যখন কনজিউম করা হয়েছে from the route of administration, কনজিউম করা হয়েছে সিস্টেমিক সার্কুলেশনে যাওয়ার আগে অবধি যে পার্সেন্টেজ অফ ড্রাগ মেটাবলাইজ হচ্ছে তাকে বলা হয় ফার্স্ট পাস মেটাবলিজম. So, this refers to the metabolism of a drug during its passage from the site of absorption into the systemic circulation. All orally administered drugs are exposed to drug metabolizing enzymes in the intestinal wall and liver. These are the two most important sites of first pass metabolism, where they reach through the portal vein. Pre-systemic metabolism can be avoided in the gut and liver by administering the drug via the alternate route like sublingual, like transdermal patch and others. However, limited pre-systemic metabolism can occur in the skin when administered via the transdermal patch and in lungs for drugs reaching venous blood through any route. So, these are some other sites of first pass metabolism. Now, extent of first pass metabolism is very high in case of propranolol, verapamil, salbutamol, glyceryl trinitrate, morphine, and with parenteral drug event, isoprenaline, lidocaine, hydrocortisone, testosterone, intermediate with aspirin, quinidine, desipramine, nortriptyline, low with phenobarbital, tolbutamide, theophylline and others. Attributes of drugs with high first pass metabolism. Now, the drug having high first metabolism will require higher oral dose compared to the parenteral dose. So, oral dose is considerably higher than sublingual or parenteral dose. There is marked individual variation in the oral dose due to difference in the extent of first pass metabolism. Oral bioavailability is apparently increased in patients with severe hepatic disease. Liver is the main site of first pass metabolism. Now, যেগুলো পেশেন্ট লিভার ডিজিজ দিয়ে সাফার করছে তাদের কিন্তু ফার্স্ট পাস মেটাবলিজম কমে যাবে, more and more drug will be available in the systemic circulation. So, oral bioavailability is apparently increased in patients with severe liver disease. Oral bioavailability of a drug is increased if another drug competing with it in the first pass metabolism is given concurrently. দুটো ড্রাগ একই ফার্স্ট পাস মেটাবলিজম এনজাইম দিয়ে কাজ করছে, তো তাহলে কিন্তু বায়োঅ্যাবিলিটি প্রত্যেকটা ড্রাগে বেড়ে যাবে। সো লাইক chlorpromazine and propranolol. Now these are the factors that affect drug metabolism, like age. The newborn babies or the premature infants, they have got reduced cytochrome P activity or the glucuronidation activity. Elderly subjects, they have got low hepatic blood flow. So, drugs having metabolism in the liver will be affected. Sex, generally in humans, less important. Species, very interspecies differences are less from in animals and human beings, but they are there. Race, like Chinese individuals, they show more basically more symptom with alcohol, that nausea, vomiting and others, because they have got high alcohol dehydrogenase activity and low aldehyde dehydrogenase activity. So, aldehyde in Chinese men, they accumulate more, leading to nausea and vomiting. Racial difference are there. Genetic variation, we will be coming to it later. Nutrition and diet. Now, persons consuming more protein diet, they will consume more cysteine, more methionine, which are required for biotransformation. So, more drug metabolism will be there. And a person taking more carbohydrate rich diet, the metabolism will be slower in them. A person in starvation, metabolizing enzymes may be inhibited. Disease, a person having liver disease, definitely the metabolism of the drug will be impaired. Drug-drug interactions already discussed, inducers and inhibitors. Now, these are some of the examples of genetic polymorphism in drug metabolism. Number one, atypical pseudocholinesterase. These pseudocholinesterase, they metabolize succinylcholine. It is a drug, it is a skeletal muscle relaxant, short acting. Now, what happens? Due to genetic polymorphism, some individuals are deficient or having less active pseudocholinesterase. In these patients, if succinylcholine is administered, it can lead to succinylcholine apnea because of respiratory muscle paralysis. Isoniazid. Isoniazid is an anti-tubercular drug that is metabolized by an acetyltransferase enzyme. Now this N-acetyl transferase enzyme, they again show genetic polymorphism, and in some group of individuals, basically they are less active. So we divide the population into two groups. One are fast acetylators and one are slow acetylators. It has been seen that peripheral neuropathy, one of the side effects of isoniazid, is more common in slow acetylators, and hepatotoxicity is more common in fast acetylators. Now codeine. Codeine is an opioid drug used for analgesic action and also for cough suppressant action. This codeine is metabolized by CYP2D6 enzyme that show genetic polymorphism, and in some individual having deficient enzyme, the analgesic action of codeine will not be there.